You're listening to Be Informed with Your NP, a weekly podcast with your host, nurse practitioner Tamara Lewis, a former nursing instructor with a strong background in critical care who enjoys educating the public, upcoming nursing students, family, and friends on the benefits of becoming an advocate for themselves as well as others. This show is designed to put the ease into easy understanding of medical conditions and other hot topics discussed with special guests and coworkers. So if you're looking to increase your medical knowledge, it's time to be informed with your NP. Here's Tamara.
Hello. Thank you for joining. Good morning, good afternoon, or good evening, wherever you are listening. Welcome back. I'm so glad you joined me for episode 2. Today we're going to discuss pain and is it what the patient says it is? In order to answer that question, let's do a little review on what pain is exactly. According to the Merriam-Webster Dictionary, pain is defined as a localized or generalized unpleasant sensation that causes mild to severe physical discomfort. In general, once those nerve endings are triggered in the nervous system, pain will cause uncomfortable sensations in the body. For this particular podcast, it's important for providers to be able to distinguish the two types of pains that we're going to discuss, as well as family members being advocates for your family and nurses being advocates for your patient. The first type is acute pain. This is pain that has a quicker onset. For example, you just stubbed your toe. And the second type is chronic pain. For this, I'm going to give the example of the good old Mr. Arthritis. And for those of you who don't understand medical humor, it's arthritis. This is pain that has been persistent for a time period of greater than 3 months. Pain can also be localized. You just received your flu shot, or you got punched in the arm. That pain is more likely to remain in that area. Whereas fibromyalgia is a perfect example of diffuse pain. It's diffuse because it affects a wider range of the body and spreads to multiple areas. So when it comes to assessing pain, what cues are you looking for? Are you looking for grimacing, squinting of the eyes, restlessness in the bed? Or are you looking for a patient that's displaying a more stoic presentation and is quiet? The behavior displayed by a patient can bring about a certain judginess with medical staff and multiple quirky comments. Here's what I mean by that. If a patient is talking with someone in their room and they appear to be having a fairly decent conversation with intermittent laughing, well, they can't be in pain. Or if someone is yelling and thrashing around in the bed, they are thought to be extra. And why do they have to be so loud? From a nursing perspective, when assessing the patient, we need to determine the severity of the pain. So for someone who is awake and alert, a most common question that's asked is, on a scale of 0 to 10, what number would you give your pain? 0 is no pain, to 10 being the worst you have ever felt. Now, referencing that previous scenario that I just gave you, are you going to rush to get pain meds for this patient? For a provider, are you rushing to order meds for this patient? Or are you just going to sit back and wait a while? What are your thoughts? Moving on to children 3 years and older, when assessing pain, we use a Wong-Baker face chart. This is a chart that has 6 faces with smiles progressing to tears. When I ask my pediatric patients to rate their pain, I refer to the faces as emojis because that's what they can relate to. And I even get some smiles in return. A smiling emoji signifies no pain, to the last emoji crying, which indicates the pain is at a level 10. Fun fact. Did you know that the Wong-Baker chart was created by Donna Wong and Connie Baker in 1983? That wasn't too long ago. This was developed to help children express their pain more effectively. And over time, it was also shown that it helped decrease anxiety as well. Now, to throw another wrench in that plan, what makes things a little bit more complicated is when we have to decipher a nonverbals patient status. Children between the ages of 2 months to 7 years need to have their pain appropriately assessed as well. This is used by the FLAC scale. The FLAC scale stands for Face, Legs, Activity, Cry, and Consolability. It's the tallying of those points that give providers a sum ranging from 0 to 10, with once again, 0 indicating that there is no pain, to 10 being a high level of pain. Another difficult challenge that I would like to mention is, what do you do when you have a patient that speaks another language? That's a barrier in itself. So while it's convenient to use a family member or friend, words may not be translated correctly, especially medical terminology, which can result in the patient not being cared for properly. So when appropriate, your first option should be to use an approved translator service. Pain should be assessed by healthcare providers during all interactions, whether during a wellness visit, a sick visit, in the urgent care setting, or the emergency room. One thing that we need to remember is that everyone has their own perception of pain, and patients will also have a level of pain that's acceptable to them as well. Remember, everyone has a different pain tolerance, so pain that is described as a level 3 to 1 may very well be a level 7 to someone else. According to the International Association for the Study of Pain, an article reads, "We also need to take into account the age, gender, education, and socioeconomic status of the patient. Each of these factors play a part on how we understand the communication of pain from others." While I was researching some info, I found something very interesting that I wanted to share. Did you know that in 1811, an English author by the name of Fanny Burney actually held her own cancerous breasts while the surgeon operated without any anesthetic? This is before anesthetics were made. She did, however, receive a small cocktail before surgery. Can you imagine that painful experience? When assessing patients, we have to take into account their cultural background. Some cultures are more verbal, like the Anglo-European cultures, while American Indians, Asians, and Hispanics are seen to be stoic and can keep a straight neutral face despite the severity of pain that they're in. That's when it's our job to pick up on those subtle cues and be an advocate for our patient. Now, as far as treatment, for a low level of pain, 1 to 3, a patient may receive Tylenol or ibuprofen because that seems acceptable. The next step up, the patient has a pain anywhere from maybe 4 to 6, 5 to 7. The patient may receive something a little stronger like naproxen or Tylenol. Naproxen tends to work a little longer in the body. For moderate to severe pain, that's about 7 to 9, 8 to 10, depending on where they are on that pain scale. A patient may be ordered Toradol again, or given morphine or Norco. And then the last would be Dilaudid. That's considered a heavy hitter. Some cultures won't accept opioid use. Some patients are scared that if they take 1 or 2 doses of a narcotic that they're going to get addicted. This is where education needs to come into play. Make sure that we stress to the patients that if they're taking 1 or 2 doses for something that's going to be short term, and if they're taking the medication as prescribed, and if they're using other medications in between, it's going to decrease their chances of that occurring. So an example that I like to give is, say in the hospital setting, a patient is given morphine 2 milligrams every 4 hours for pain. But at that 3-hour mark, the patient's pain level is high. We can either ask the doctor for maybe a higher dose of morphine, maybe 4 milligrams every 4 hours. Maybe that will hold the patient over. Or we could do 2 milligrams every 4 hours, and at that in-between mark, maybe give something else like Toradol. So that way we have pain being covered from a couple different angles. Now, I must address the public for a short spell. If your child is in pain, or if you're in pain, or a family member's in pain, please try something at home prior to coming to the ER or the doctor's office. I can't stress enough how you don't want your child to suffer. We don't want you to suffer. So medicate, medicate, medicate. We will believe you. In addition to pain medications, there are alternative methods that can be used to try and alleviate discomfort as well. You can listen to pleasant sounds such as ocean waves, light rainstorms, even forest sounds with birds tweeting. You can listen to those on your smartphone, on your Alexa, or your Google gadget, whatever it is that you have. YouTube has many calming channels to view as well. You could get a nice massage or a light body rub, ice packs, repositioning, or just being in a dark and quiet room, to name a few. What helps you when you're in pain? Do you take something right away, or do you wait and see if it will pass? Communication is key. For those of you who are listening, for yourself and for your family member, it doesn't hurt to ask for better pain management, especially if you see your loved one or yourself is not having any relief from the current plan. For nurses, while you may have an order for medications to be given at certain intervals, maybe you can request something else from the doctor or get something else ordered in between time, like I had stated earlier. As for providers like myself, look at your patient, be open to offering other options, and if deemed necessary, order appropriately. So to answer this podcast topic, pain management is complex. Pain, as passionately addressed by the late Margot McCaffrey, it's truly subjective. Her influential definition resonates with clinicians like myself and patients like you. It's whatever the experiencing person says it is, existing whenever and wherever the person says it is. In other words, pain is personal, and the reality of pain is shaped by the individual's perception and expression. Thank you for sharing your time with me. I have included pictures of the different pain scales discussed during this podcast, as well as a couple links to articles discussing pain. Disclaimer: this podcast is to provide education and not medical advice. Please consult your physician as they know your medical conditions, medications, etc. I look forward to seeing you next week as we discuss advocacy, what it means, and who will stand up for you in your time of need.
You've been listening to Be Informed with your NP. We appreciate you tuning in. If you have any questions, please email Tamara at beinformednp@gmail.com or comment in the chat section of the podcast. Be sure to follow on Instagram and YouTube so you can stay up to date on the weekly topics. Remember, it's best to be informed. See you next week.